Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, it's everyone's favorite time of the week. It's Saturday morning coffee talk. I've got a relatively good bit on the docket today to talk about. I got some great feedback on the episode with Dr. Scott Weingart and Nick Gioni. Everybody seemed to like it. They seemed to find it very valuable. So thank you for that feedback, and thank you for those two doctors for coming on to the podcast. Speaking of giving me feedback on things, if you want to contact me, please do. I ask that you contact me on Instagram if you can. Patreon subscribers, you know that you can contact me on the Patreon app. I keep those notifications on. I do tend to give a little more attention to those messages because the subscribers are paying $3 a month to support the podcast. So yes, actually one of the questions I have, actually two of the things I have on here today came from Patreon subscribers. $3 a month. There's a link on my bio on Instagram if you'd like to support the podcast. It does go a long way and it helps greatly. So Patreon followers can contact me on the app, but if you want to contact me, I ask that you contact me on Instagram DM. That's where I do the majority of the podcast business. I don't have, I think there's a World's Okayest Medic podcast page on Facebook that I think I created many, many years ago. I don't pay any attention to it. So don't contact me on the podcast's Facebook page. Also, you can contact me on my personal Facebook account, but I don't look at Facebook Messenger really. I don't keep the notifications on. And then I feel bad when I'll log on and I'll see that there was a message somebody sent me from 4 months ago. So contact me on Instagram DM if you want to get a hold of me. That's the best way to get me. Moving on from all that stuff. The AHA stuff, following up on that kind of seems to have died down a little bit, at least as far as all the OMG factor on the interwebs. It knocked my microphone. It kind of was like a flash in the pan. The news cycle has kind of come and kind of gone, and that's why I wanted to get that episode out so quickly. I will say that Dr. Peter Antevi did a wonderful webinar on his opinions along with expert input, and it wasn't an echo chamber. Not everybody agreed with everything, but it was a very academic discussion, very data-driven, very science-focused on what people think about the new AHA guidelines. I believe that you can still watch a recording of it. It was like a 3-hour webinar. I didn't see all of it, but what I saw was absolutely excellent, and I felt very well informed, and I felt like I left that webinar significantly smarter than I did when I logged on to it. So if you get a chance, go to whatever, I got to it off of Dr. Antevi's LinkedIn site or page. I don't know what the verbiage is because I'm getting older and I don't know the social media lingo, but I'm sure you can find it anywhere. I did see in the comments a lot of people just kind of bonsai attacking the AHA, which I kind of did on some things, not saying that it's wrong to do that, because you all know that I strongly support defunding the AHA. And I think that we need to look at other sources of experts for the way we tailor our resuscitation guidelines. But I do think that some of the bonsai attacks against the AHA were a little over the top, and some you could tell people were just repeating what they heard other people say and putting their spin on it without actually reading the literature and knowing what they were talking about. And I think that that is always a bad look. And on the other side, I saw a fair amount of apologists for the American Heart Association. And one of the things that I saw repeatedly was people saying, hey guys, the AHA didn't change anything with these guidelines, which is true. And I talked about that on the podcast. If you want to listen to like 45 minutes about this, you haven't listened to the podcast, I ask that you go check it out. But yeah, the apologists saying that, hey, the AHA didn't change anything. Well, one, that's kind of the point, because things do need to be changed. Like the epi thing. In the webinar that Dr. Antevi hosted, it was discussed that epinephrine has an NNT, a number needed to treat, of 112 patients. And The science, in quotes, of using epinephrine Q 3 to 5 minutes in cardiac arrest was just kind of a best guess on how we should be giving epi. And the basis of giving epi in cardiac arrest came from and I totally believe this, came from a study in the 1960s of 10 dogs. I've talked about this a lot on the podcast, how if you dig deep into the why of what we do and not just the what, you will find that a lot of what we've been doing forever is based on shaky science and a best guess from decades ago. Getting back to the point, we need to change stuff. And the AHA, through all of this alleged hard work, didn't really change anything. The second thing is that when the AHA says that something is not recommended or that they don't support its use, that carries a lot of weight. And people are going to look at that and they're going to extrapolate that as the American Heart Association says not to do this. You get a lot of knee-jerk people who aren't going to read the meat and potatoes, and they're not going to say, well, they didn't really say not to use it. They're just saying it's not recommended and it's class 3 evidence. So let's look at what that really means. No, there's a lot of lazy administrators and there's a lot of lazy medical directors who are just blindly going to look at what the AHA says and say, hey, they say it's not recommended. We're not doing it. End of story. End of story, like Andrew Dice Clay used to say. When the AHA puts out a statement like that, it carries a lot of weight. So to the apologists, just because the AHA didn't say to not use mechanical devices, saying that they aren't routinely recommended is like when your mom used to tell you, hey, I'm not saying that you can't do blah, 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 but I wouldn't recommend it. And you all know damn well that that is your mom telling you, hey, you damn well better not do this. Now, is that what the AHA said? You damn well better not use mechanical devices? No, but that's what many, including important decision makers, that's the message they're going to take from their statement. That's what I have to say about the AHA stuff. Also, from reading the comments and knowing a number of people who wrote comments and knowing their background, and this is just me personally. This is not me like the position of the world's okayest medic podcast. No, this is just my opinion. And this is a Saturday morning coffee talk as I take a sip of coffee. So I'm going to tell you what I think. I have a really hard time reading a comment and accepting input or advice from someone who doesn't actually practice what they are discussing or what they are opining about. Now, I know that there's tons of flaws in that thinking, but that's my honest take. It's like when the deputy chief of administration, who's been doing budgets for 15 years, and the only place they have driven their take-home car in the last 10 years is between headquarters and home. Like, I don't really respect your input. I know that's kind of nasty to say, but it's just the truth. Now, I know that there are scientists, there are academics out there. Paul Sheets and I in our podcast kind of talked about the balance between being a full-time educator, and I think you can apply what I'm talking about as far as administration to this. The balance between needing full-time professionals who do this non-actual clinical operation stuff versus actual people who are doing the operation stuff who can impart good opinions and education. But just me personally, when I see somebody who has worked at the Office of EMS for 30 years or who has worked in a policy role telling me how I should run a code, I just think, shut the fuck up. That's just my input. Okay, moving along, looking at my agenda here. I got a couple of things to say about blood. First and foremost, I have to eat my words a little bit, and let me pull up the text message here. I don't make a habit of reading my personal communications with people. I had a shooting last Friday night. It was an abdominal wound, the ground ALS. They did a great job with him per their protocols. The patient was in decompensated shock. The ground ALS doesn't have blood products yet. They're getting them. So they gave him a 500 bolus of saline. Shocker, it didn't work. The guy's in decompensated shock. He's on his way to dying. And we gave him a unit of blood. And by the time we got to the trauma center, he was being evasive with questioning. This was actually, we found out, his third time at this trauma center as a gunshot wound victim. But the blood saved his life. He is alive and well as of the other day when I did the follow-up. He's going to be absolutely fine. So the ground ALS had him on a nasal end-tidal CO2. And as you know, I've been on this whole big thing about like, oh my God, we are using end-tidal CO2 far too much. And the only thing that I use it for is to monitor whether the patient is ventilating or not during transport. And I don't really use it as a marker of perfusion. And as you heard on the podcast with Scott Weingart, he was like, oh, it's an amazing tool to monitor perfusion. When he said that, I kind of was like, I know people who have been listening to my podcast are going to be zeroing in on this. So that night, I had the shooting a few hours after I recorded with them. So ground ALS had the patient on end-tidal. His end-tidal was 29. And I texted my friend, Dr. Mark Peel, who loves the Saturday morning coffee talks. He texted me that he was listening to the Saturday morning coffee talk. And I replied to him. I said, so I begrudgingly said to myself last night, Dr. Peel was right. We had a scene flight for his blah, blah, blah shot, abdominal GI wound. He was hypotensive at the scene. Ground EMS had him on a nasal end-tidal. BP was in the low 80s and end-tidal was 29. Gave him a unit of whole blood and his end-tidal climbed up to 48 by the time the unit was done. Granted, his blood pressure rapidly improved as well. And I didn't notice that the end-tidal changed any faster than his blood pressure. Nevertheless, I sat there and I kind of frowned and I thought that I might have to eat my words and mention this on the podcast. I will say, though, that on this particular flight, it made no difference in his care. So I just had to mention that since I have put out stuff where I question the utility of it as a perfusion marker, I'm not saying I was wrong. I do stand by the stuff that I have put out where I have said, hey, the science, the data behind this end-tidal as a perfusion marker is really shaky stuff. Like we monitored end-tidal in 12 iguanas, stuff like that. But I will say that I noticed a big jump in his end-tidal as we perfused him with whole blood. And I thought like, durr. So it did not make any difference in his care. His blood pressure improved just as rapidly as his end-tidal did. My question is, if it was in reverse, would his end-tidal have dropped quicker than his blood pressure, or would it have just been in tandem like I saw with the rise? I'd like to see. So while I am not reversing course on end-tidal as a perfusion marker, and I'm not saying that I'm going to come out and say that I've completely changed my mind on its utility, because again, it did not make a friggin' damn bit of difference on this call. I am going to start, and I'm going to report back to all of you, and I'm going to track it. I'm going to start using end-tidal CO2 on sicker patients routinely. And I'm going to see if it makes any bit of difference. I might even write a paper on it. And I'm not saying I'm going to use it on every single patient, like the person from the local drug and alcohol rehab who has the kennel cough and is absolutely fine. I'm not going to monitor their end-tidal, but like the shooting, perfect candidate to monitor their end-tidal, see if there was any clinical benefit to using it. I used it recently. I even started a little note in my notes app for when I use it. So I have on here 64-year-old female, SVT palpitations converted with adenosine, and I have some data, lowest end-tidal 32, highest 34, some stuff about shock index, was short of breath, was oxygen used, did I notice a trend, were there any issues, and was there any clinical value, and I have no. So I'm going to keep track on patients, and I will report back to you if I change my mind. I'm not totally convinced, and I'm not convinced just off of one patient, but I can't deny what I saw. Will report back. Getting back to the other blood stuff, after that shooting call, I got a text from a friend who's a paramedic in another county, and it was in reference to a 7-year-old pedestrian struck. And he's like, I got a text from my chief who was on a call with this 7-year-old pedestrian struck. And the text read, I will say, seeing a pediatric patient crapping out in front of your eyes, heart rate went from 78 to 60 to 50 and then to 40 gave blood, and then the patient starts waking up and crying mid-blood administration is crazy. And he said, I am a true believer in giving blood. He just wanted to reach out to me and tell me that amazing story that it works in peds. And then he said some not so nice words about people who have been trying to block pediatric blood administration. Also, by the way, congratulations to Boston MedFlight for being named Program of the Year at this year's AMTC conference. Oh, by the way, I want to give a shout out to the LifeFlow device. This text from the paramedic about the 7-year-old pedestrian struck. This service has the LifeFlow device. That's the gun that rapidly administers a unit of whole blood in like 2 minutes. I did a reel where I demoed it before. This pediatric patient who went from dying with a heart rate of 40, which in hemorrhagic shock is a peri-arrest patient, to then waking up and crying mid-transport. That's thanks to the blood and thanks to the rapid administration from the LifeFlow. So boom, there you go. So another blood administration thing that I heard that bothered me, and this came from a flight nurse. There was a discussion about how all the helicopter services around us now have blood and how we now have it. And this one flight nurse from one particular service made a comment that I don't see what the big deal is. 1 or 2 bags of blood is not going to save anyone's life. And I just thought to myself, I didn't hear him say this because I would have chimed in and put him in his place. But when I heard this reported to me, I just cringed and I thought, oh my God, yes, it is going to save someone's life, you dumb motherfucker. Is it going to fix the problem? No, it's not going to fix the problem. If you have a hole in your aorta and you are dumping blood into your chest or abdominal cavity and you give a unit of whole blood, without repairing that hole in the aorta, that whole blood's just going to go thunk right out the hole and the patient is probably going to die. If you have life-ending trauma, the only thing that is going to fix that patient is a trauma surgeon. We're not going to fix that. But the point of the blood is that while it is not the thing that ultimately saves the person's life, that is the surgeon, the blood facilitates getting the person from point A to point B, which is the operating room, in a salvageable state. In essence, it keeps them alive so that their life can be saved. And it keeps them alive way better than what we've been doing for the last 30, 40 years, giving crystalloid. It's just, the science is clear. And it just proves my point that these naysayers to blood and these people who don't believe it, they either don't know physiology, whether they went to Harvard or not, or they're just in denial, they're clouded by ego, or they're just retarded. Maybe like this flight nurse. Rant over. What else? While we're talking about how you can't fix stupid, I posted some stuff about the albuterol thing. I cannot do it anymore. You cannot fix stupid. I got a message from a well-known paramedic who is a content creator, and she told me, oh my God, I'm at this continuing education and the clinical coordinator here is talking about how albuterol may cause flash pulmonary edema in the patient with CHF, and he is lambasting a crew for a patient who had acute decompensated heart failure and was wheezing. The crew gave albuterol, and he's talking about how much that put the patient at risk and could have fucked them up. And I just was like, oh my God, I have said now that if you believe this myth that you give a dose of albuterol or a duoneb to a patient and they have pulmonary edema and they flash because you've opened them up and like now their alveoli are flooded, you are dumb and you should be disqualified from being an administrator, a supervisor, or a clinical coordinator. And I think you should be put back through a field training program. And if you don't pass field training, you should leave the profession. I normally don't like definitive statements like that. Like, oh, if you think this, you should lose your license. But it's gotten to the point where this myth just needs to go away. So I did some memes because I think that's a good way to combat stupidity, is to make fun of the people who are perpetuating stupidity. And what better way to do that than through memes? So I did some memes about how albuterol does not cause flash pulmonary edema. And these people who perpetuate this myth, largely boomer medics, older medics, are just wrong. I got a couple of messages and comments. And as you know, I normally avoid the comments. I don't really read them, and I certainly don't engage in debate. I very, very occasionally will respond to a comment, but I've decided that this is now a cause of mine, and I've got to push back against stupidity, and I have to call people out in the comments. And I'm kind of doing so aggressively. Example, a guy wrote, yeah, well, you could set your clock to it. Once we had CPAP, it was a non-issue. You just put the neb in line. A lot of us were doing this at a time where they were so tight, you had to bag the treatment into them, 3 nitros and paste, and boom, they flash. You give them Lasix and they're smiling at you before you get to the hospital. Got to be routine. CPAP didn't exist at all at first, but then for a while, it was a machine the size of a small car in the ICU. About 2004 to 2005, they came out with the first EMS CPAP, and the early model sucked down a portable O2 tank in about 15 minutes. By the time I stepped off, we had full mode ventilators, and we were doing therapies only a respiratory therapist could pull off otherwise, which, yeah, thank you for correctly describing the evolution of CPAP. And I wrote back to him, the decompensation and pulmonary edema happened because the patient was dying, not because of the albuterol. Once we got CPAP, then yeah, our patients got better. The albuterol did not cause the crash. The crash was going to happen, and albuterol just didn't do anything to stop it. Don't be deceived by my boyish good looks. I was there when CPAP came onto the scene too. So the guy replied back, of course they were dying. The albuterol didn't make them sick, in quotes. It opened the floodgates because the bronchoconstriction was the only thing holding the river of lung butter at bay. Oh my God. I'm not here to debate physiology with you. This was literally hundreds of calls, all exactly the same. Not just by me, but pretty much every other medic I ever worked with. And my reply was, I'm not going to debate physiology with you because you clearly don't know what you are talking about. Where did this ocean of pulmonary edema come from that the swollen bronchioles was tamponading off? This makes no sense. Pulmonary edema comes from the vasculature and into the alveoli, not this cascading flood from above that is heroically held at bay by the constricted bronchial smooth muscle. And I did just that. I debated physiology with him, and I didn't get a reply. Guys, girls, they, thems, this is a myth. It is a bullshit myth. This is strict timing. As the guy appropriately said, they didn't have CPAP back in the day. I have said this, and this is why medics saw so much flash pulmonary edema back then, because you had the patient who was in decompensated heart failure. They had wheezing because their lungs were full of liquid, and that causes irritation, which causes wheezing. So they heard wheezing, they didn't have CPAP, so they gave him a neb, and then the patient got worse. And they thought, oh my God, it was the neb making the patient worse. It was just, no, the neb was an ineffective treatment to stop them from dying, to stop them from having even worsening heart failure in that vicious cycle that is worsening decompensated heart failure or SCAPE or whatever you want to call it. So yeah, of course, they got worse after they got albuterol. This is classic, going back to Stat 101, this is classic correlation does not equal causation. Did these old medics in like 1985, 1990, did they give albuterol to wheezing patients and then see them get worse with pulmonary edema bubbling out of their mouth and nose? Hell yeah, probably they did. But just because there was a correlation, the albuterol was not the cause. The albuterol just didn't help. And yes, once you had CPAP, the patients got better. And the medics probably were like, hey, we're not giving albuterol nearly as much now that we're using CPAP and the patients are dying. So that confirms what we thought, that albuterol was causing this death knell of inducing pulmonary edema. So I do understand why some people back in the day thought that, but it physiologically does not make sense. This is a crusade of mine to dispel this myth because I got dressed down by an FTO back in 2007 for this. And when I was like, I've never heard this, can you explain this to me? And he explained it to me, and I was like, that's the dumbest fucking thing I've ever heard. And it became this big argument, and he documented about my attitude on my evaluation sheet for the day. And I had to have a talk with the education coordinator. And I was right. And this is a grudge, character flaw. I do hold grudges. So this is a cause of mine. And I've tried not to just be me saying this. I've had pulmonologists come on. You heard Scott Weingart on the podcast last week, where he's like, if they're wheezing and it's a cardiac wheeze, he was like, just give them the albuterol. That was a verbatim quote. I've had doctor after doctor come on here. I've had Melody RT come on here to talk about the albuterol not causing flash pulmonary edema thing. Not specifically just that, but it's been brought up. It is madness. It doesn't make sense. And I think, honestly, if you are withholding a beta 2 agonist from the wheezing patient because you are concerned that you're going to trigger flash pulmonary edema, you are doing harm to the patient. 100%. Those patients need that beta 2 agonism. And there you are with a treatment in your bag next to you, and you're not giving it because of a bullshit myth that you've heard from boomer medics who weren't correctly interpreting what they saw back in the day. This is dogma, it's bullshit, and it only exists in EMS. You see doctors, nurses, respiratory therapists, and doctors from all disciplines, emergency medicine, internal medicine, pulmonology, cardiology. I've seen them all in my comments, and they're all like, WTF, we have never heard this before. Where did this myth come from? Okay, let's get to the last thing I'm going to talk about. And this comes from a Patreon subscriber. And he provides a question. And this is totally switching gears. He writes, I've been a 911 provider working for the same agency to this point. It is a tax-supported third service agency with high standards, long transport times, and well-rounded people. I've enjoyed the long transports with high acuity patients. It's kind of a lengthy question, but it's a good question nevertheless. Our medical director is supportive and pushes us to treat our guidelines as just that, blah, 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 RSI, vents, good toolbox, yeah, blah, blah, blah. Anyway, he's going to move. So he's doing ride-alongs with area services and to find where he wants to work at his new geographic location where he's going to be living. And he rode at 2 services. One was fire-based, and the other was a third service EMS only agency. And here is his dilemma. He writes, the third service agency I visited was disappointing. The providers were initially not friendly to me and definitely not friendly to the patients. The medicine, while ostensibly, good word, progressive, in quotes, on paper, was backwards in practice. And I noted a provider using Narcan on an alert and oriented GCS 15 patient to see what would happen, and atrocious scene management of a significant traffic accident, borderline MCI. Uniform standards were lax. If I had to call it something, the agency felt burnt out and overwhelmed. My experience with the fire department was radically different. The shift was very friendly to me and compassionate with the patients. While their guidelines are called protocols and treated as such, the worst I saw was blood glucose being considered a vital sign. Whatever. I would not be practicing at the same level as I am used to until I jump through the hoops put in place by the medical director, and I would be dual role, and I have little interest in firefighting. I don't know how I see myself fitting in either context. I sense that I would frustrate some folks at the first agency as I hold myself and my crewmates to high standards, including having a squared away uniform. Very good, because nobody likes a fucking slob. On the other hand, I am proud to be a paramedic, and medicine with some technical rescue on the side is all I want to do. At some point, I would like to be a flight medic. What has your observation been of medics who go the dual firefighter role, and blah, blah, blah? What would you do with my dilemma? Okay, first off, I know plenty of flight medics who have been fire medics. You just need good EMS experience, patient care, patient contacts. I could be wrong. I've been wrong before about things. They typically don't look at your agency's protocols when you apply to be a flight medic. It's not like if it's between you and another candidate, they're splitting hairs between like, all right, let's see what this person's able to do with their agency versus what this person's able to do. No, they're looking at you, the candidate. So just be smart, know your job, know your craft. Doesn't matter whether you're a firefighter or not. I know phenomenal fire medics, and I know some idiot fire medics. I know some phenomenal EMS only medics, and I know plenty of idiot EMS only medics. But as far as what should you do choosing between the two agency, I think hands down, I would choose the fire department. Culture is everything. I don't give a damn what your protocols are. Culture for me is everything. If you think you're going to change a culture, you are probably wrong. You are not going to single-handedly. I know this is not Jocko Willink extreme ownership, but if you think you're going to walk into a place as a new hire and change 30 years of organizational culture and the way things have been done always, you're just wrong. You're likely like 99.999% going to fail and might actually develop a bad reputation for being a little shit stirrer, which people like me don't mind that reputation. All right, I think we're good. Had some technical difficulties. It just completely stopped recording on me, and then I tried to re-record it and it didn't record. Anyway, where was I? If you think you're going to change a culture, you're probably not. So I pick culture over protocols. Now, all of the progressive stuff that the third service agency may be doing, like all the toolbox and the cool stuff that they do, that's great. I think that we should be doing it. That is a draw to a agency for me. But that's like what? A small percentage of the job. Like, are you really going to go to a place with a shit culture because you can do POCUS or, we can push ketamine and rock? I mean, everybody hates their job and they have a crisis of people calling out, nobody wanting to pick up shifts. And there's mental health problems at work and people are burnt out and they look like freaking slobs and the gear's falling apart. They don't take care of themselves, take care of their stuff. But we can push rock to facilitate intubation. Is that really the important thing? I said on a past podcast that all the stuff I just described, that 75% of the calls that we go on are totally mindless and totally routine. Now, 20% of the calls that we go on, they're pretty sick to some degree, and that might require a little bit of intervention. It might require a lot of intervention. Nevertheless, the intervention that we provide is pretty routine. And they're relatively, well, sometimes challenging. They're pretty easy calls. But then 5% of what we go on are the high speed calls or the calls that require all the tech, all the fancy tools. So let's say the fire-based agency doesn't have the awesome tools to use on that 5%. That leaves 95% of calls that you can probably perfectly manage just fine as a paramedic. I was talking to somebody from California, and they were lamenting to me about how restricted they are in that state as far as protocols. And I was like, that is very frustrating. But even in states, services, projects with crappy protocols, like 85% of the patients that you encounter, they're perfectly fine to manage them, to get them from the hospital. It may not be sexy. It may not be overly stimulating or fun, but they're perfectly adequate. So I would go with the fire department. That's just my 2 cents. And with that, that's the coffee talk for this week. I will Monday or Tuesday be posting the re-recorded episode with Mike Damcott about AI. It was a great talk. I know some people may go, I don't know if artificial intelligence really gets my proverbial juices flowing, but it was a great discussion. I had a great time. So look for that this week. Stay classy.